flexion. Okay? The key to bringing segmental tension in the cervical spine is lateral flexion. And that means segmental lateral flexion. So I don't ever want you to lock a joint out, because when you lock, what does that mean to you when you lock a joint out?
Death.
That hurts, right? I mean, remember back to your posology days where you're like, and they're like, okay, I'm not there yet. Well, you can't go any further than that. You can't do that to a patient and go, okay, relax. They're like, right? So what we want to do, though, is bring segmental tension. So I want to create a fulcrum right over the spot that I want to move the bone. Okay? The key to doing that is specific lateral flexion. So right now, I think the biggest problem that people have with occiput is that when they try to adjust occiput, they do this to the neck. I haven't done anything to isolate occiput, right? What I need to do is occiput is a condyle sitting in a bowl. So what I need to do is roll the bowl. So when I want to adjust occiput, I need to bring tension this way. First thing I'm going to do is roll it, and then from there, I can adjust. So I brought segmental tension to the joint, but I haven't locked them out or made them, have eye spasms or anything like that. Okay. So slouch down a little bit for me. Don't fall off the chair. All right. Okay. So that looks, I'll set up on the side first so you can see. So what I'm going to do is take my thumb here. The whole web of my thumb is going to sit on his occiput. Okay? It will slip. Especially when you're first practicing, it will slip because you're slow, right? You set up and you're like, oh, what am I going to do? And by the time I get there, it slips. When you get proficient at it, you're going to set up and move through it and adjust all at once. You will slip by the end of it, but by the time you get through it, you've already moved the occiput into that. Okay? So, again, I'm going to give him my shoulder so that I can stabilize his head. Okay? And then I'm not like pinching his head, but I am keeping my fingers active that I can stay on my contact. Okay? And then to get my contact, I'm not just rolling it here, I'm actually going to follow with my body. Okay? And my fingers are going to follow that roll so that I stay on my contact. Okay? So from here, I'm going to roll it. See how my arm comes in? I follow it. Spin my hand down. I'm going to get the rest of it. There's the joint. Relax your head. Let it fall. And from here, okay? So it should be that easy. I'm not a big muscly girl, right? Let's see. Can we turn the chair around on the other side? I have a little bit more experience. So that's the only difference between me and you. And the license.
I mean, it looks like a monkey could do this.
Okay? So I'm here. Laterally flex. Roll it in the bowl. There. You feel it. There's the end. Spin my hand down so I'm creating some pressure here. I'm going to roll it this way. There it is. See how my body's gone around it? So now my arms stay nice and loose so I have the rest to go. Okay? It looks like a lot of rotation that his head is spinning. It's only because I'm coming through and then it spins at the end. Okay? It's just the continuation of the motion. It's already been adjusted by then. Okay? Question? All right. While I have you sitting in a chair, let me show you. Do I need to show you thumb web for the rest of the cervical spine? Do you want to see it? Because it's really the same as what we've been doing.
How about just a really low one?
Just a really low one? Okay. Always looking so sharp. Except for what? Well, I think I saw you once in jeans or track pants or something in Gonstead, but then after that you started dressing up. I don't know, maybe you went to a seminar or...
Well, it's funny, like one day I didn't dress up. I got called out in class by a speaker, and I was kind of ironic.
You students dress like that kid right there. We're like...
Okay, so if I have a lower cervical, what I'm going to do for my thumb web, okay, is I'm going to try to get, again, my thumb web on the articular pillar, or as close to it as I can, which means that my thumb is probably going to cross midline if this is the spinous. But again, my thrust is coming through here, the web, not through my finger, not through the tip of my thumb. When you go in to do this, if you set up like this and then put it down, that's not right. You want to take your skin slack out and get that web on it, okay? And then your web will be where you want it. So what you want to do, if I'm going to set up on the left-hand side, I'm going to start, depending on how much tissue slack my patient has, I'm going to start to the right of the spine, and I'm going to take my tissue slack toward my contact, okay? So I have it right there. And then everything else, well, looks pretty much the same. But I'm going to come in here. Step away. Relax your head. There. Okay? So again, not a lot of rotation, but I'm aiming right towards Tina, actually. Pretty much. Right?
Dr. Lederman?
Yes.
So like our energy is coming
Your
right
energy
through,
is, yeah, basically
right there.
through right there.
Okay.
The thenar side of your web. Okay? Can we have you go to the other side? Sorry.
Oh, sorry.
So again, but did you notice, what did I do first?
Motion path.
I laterally flexed,
Oh.
right? I laterally flexed to that segment. So again, if you're doing occiput, you're here. If you're doing C1, a little bit further, C2. You know, and it depends on what their range of motion is. He's flexible, but he's not the most flexible down there. So I don't have to get his ear to his shoulder to do this, right? So again, I'm starting towards the left. I'm going to come over to the right. Particular pillar's right there. Okay? Chin. And I'm driving in with my hand. Not hard. I don't have this knife edge. I'm not choking you, right? It's not uncomfortable. Right? Put your head straight again. But I'm starting to create that fulcrum with my contact. Spin. Get the rest of it. And I'll step away. Just let your head relax. Okay? You see that action, that little bit of arc at the end? Because there's no straight lines. The vertebra has an arc to it. Okay? Good. Questions about that one? That's our seated thumb web for the rest of the cervical spine. Pretty much works the same way as the occiput or the atlas, but now I'm on the articular pillar area rather than the TDP of atlas or the nuchal line of the occiput. Okay? Everything else is pretty much the same. I'm going P to A, slightly I to S, okay, with a little bit of an arc. Okay? And lateral to medial, of course, because depending on what you're referencing. Okay? Well, sorry, I'll get your question just one sec. When you're telling us on the test your line of correction, make sure you let us know what you're referencing. Because I always say lateral to medial. I'll tell you why I always say lateral to medial. Because in my mind, my reference point is my spinous process. I am always, no matter what I'm doing, bringing the spinous process to midline. That's where it's supposed to live, right? That way I don't have to think, okay, if I'm on the right side, I'm going medial to lateral over here, or left to right, or right to left. I'm always going lateral to medial and bringing the spinous process to the midline. Okay? It works for me. Take it if you like it. If you don't worry about it.
So when you're doing that, your force, is that just strictly an arm force, or are you like throwing your torso into it a little bit?
It depends on my patient. If someone who's a lot bigger and Jordan, right? Jordan. Getting your name right because I called you something else last time. Jordan has a much bigger neck than my hand. I probably wouldn't do this adjustment on him necessarily. But if I was, I'd probably get a little more in there with my body and throw my body into it more. Right? It depends on your patient. You might need to do that with your dad. Right? So, but notice that when you're setting up, this is something that I notice a lot, that when you're setting up, you guys have learned to kind of stand back here, and you're very stiff and up here. Okay? This is like being an athlete. You have to get your body into it. I'm bending my knees, I'm bringing my body around the subluxation. I'm here, I'm following through, and then I'm, going to thrust. That doesn't work. You got to get into it and feel it. Okay, so you take out the slack with your body. That way your arm can stay nice and supple and soft, so you have the speed to go through it. Okay? Good? Good, good. So that's the seated cervical. I think that's the one that we just, let me remove my pen from that page. Remove the subluxation. No, that was the pull. Okay, so let's do the seated cervical pull. And maybe that's it. See? Okay, seated cervical pull. This is a really, really good move. There's a couple of changes that you can make to it. When my husband learned this move, this is what he learned to do. This is scary.
Oh.
Okay? Pull.
Seagal.
Yeah, don't do that. So if you see this in a diversified manual, that's probably what you'll see. You're supposed to like drop your head and he set up on me once like that, and I said, you actually thrust all force. Okay. So seated cervical, if you have someone who's small enough when you're doing this adjustment, the perfect line of drive is going to be right here at their knee. So on someone who's smaller than I am, which is not a whole lot of people have kids, right? I would actually straddle their knee, because this is going to be the perfect line of drive. Okay? If you're working with an adult, especially an adult of the opposite sex, it's probably not the best idea to straddle their knee. Okay? Especially if they're bigger than you are and you're like, their knee is too high. It's just not good. But you know what happens? In lab, I see it all the time, and then I get a call from the clinic doctor across the street going, what are you showing them? Because I have girls over here who are straddling their patients. I'm like, okay? I just want you to know that if you have a patient who's smaller and you need to get that line of drive, you're going to explain to them, in order to do this, I need to, so you're going to let your leg down, sure, knee out. So in that case, I would do this and say, I need to stand here to get the best line of drive to correct this subluxation. You know, in some cases, depending on who you've got, if you're a young, good-looking female and you've got a male patient, bring an assistant in with you. Okay, just be smart about it. Girls, you'll get hit on in clinic. You will. Okay. If you can't manage that, then you're just going to stand as close to the side like this as you can. Okay. What you want to do for this adjustment, again, this is a rotary restriction that you're going to be using it for, or a coupled motion restriction. You're going to laterally flex over your contact, and you're going to drive basically down the shaft of your arm. It's going to be like this. Okay, a pull into you. This is an anterior, seated anterior pull. Okay, so I'm going to set up with my finger on the articular pillar of TBP. Okay. Again, for me to take my skin slap, what I'm going to do is start across the spine, bring my skin slap, tissue slap over. So again, my finger may cross the spinous process, but that's not where my drive is from. On this adjustment, I personally take my contact as close to my palm, thank you, as I can. Other people like to take their contact out here. The reason why I don't do this is that because it kind of gets pokey, and I find that I end up poking the patient and hooking instead of pressing into my palm. So when I do this and I take the contact, I'm actually going to make this action with my hand. I'm trying to get my proximal phalange into my palm, okay? Like that. So do you want to turn, let's turn the chair around so they can see the contact.
That one?
Yes, that way. Okay. So if this is a left rotation restriction, I'm going to find what I do. I'm going to come here. I use my middle finger. You can use, on some instances, like if you're higher up in the spine, you might want to use your index finger so that you're not butting up against the head. So I'm going to take my contact this way. Okay? And I'm going to take this hand and I'm going to cup the ear. Okay? So my hand is like this. Fingers pointing posterior encephalad. Okay? And I'm going to use this hand to slightly traction and laterally flex the head, creating a fulcrum over my contact. So I'm still pulling in here. See this? So it's here. And just relax your ear in my hand. Let it go. You wait all day. And then it's a pull towards you. There. Okay? On the other side. And again, remember, when I'm showing you these different adjustments, I'm showing them to you as a tool to put it in your tool bag. This will not be the adjustment that you will use for everybody, right? You pick and choose the adjustments that best fit you and the patient that you happen to be working on. If it worked for everybody, we'd just show you one adjustment and you'd get through here a lot quicker, right? So I'm pulling into my palm. See that contact right there? Okay? I'm going to traction, laterally flex, and just drop your ear in my hand. Don't force it, just let it fall natural. Look at a little movement there. Okay? That rebound movement. And that's the seated pull adjustment. Questions?
So that was LP?
That would be an LP, yes. Perfect? Did I pass?
Oh, no. Yeah, you did.
Okay. Any questions about those two adjustments? Yes.
I'm just trying to get around the coupled motion of that because we're saying it's an LP, but then we're laterally flexing it.
Now,
To the
again, so good question, Jillian.
Yeah.
Jillian is asking about the coupled motion. If we have, this could be a straight rotary restriction,
Okay.
in which case it would be an LP. It could also be an LPS, which would also be a left lateral flexion restriction.
Okay.
So you could have two things going on here, or just the one rotation going on here. Okay? So it works well for both of those things. Good? Does that answer your question?
Well, even you're laterally flexing it to the right, bringing that spinous more or less. Right?
I'm laterally flexing. But you're talking about normal coupled motion, that the spine should go that way in normal coupled motion. It doesn't always.
Okay.
Okay? That's why we have to figure out what we did before. Okay? Anything else? Yes.
Can you do a pull like this with the occiput?
Can you do a pull like this with the occiput? I've never tried. I think it would be hard to get the line of drive that you need for a posterior occiput doing it this way. I think it would be hard to hook on and get that, because you'd have to come this way towards you. Try it. We can make up the Armando, what's it, Flores adjustment. There you go. What else? Are you blooming? Okay. On some people, this is a golden adjustment. On other people, they'll hate it. They can't relax in the chair. They can't, you know. Yeah.
Using some of these techniques, do you do anything about
Yeah, I think a big one.
an
Yeah.
occiput that's subluxated into, let's see,
I can't hear him.
an AS occiput? You do
We haven't done
anything?
AS occiput.
We will though?
We will.
Yep.
I'm deciding on what moves I want to show you for AS occiput. Because really the best move for an AS occiput, believe it or not, is that column technique that you do. Oh, but it works. You don't have to get a cavitation for it, but it works. And it is the best because it's the most sort of direct. You're actually like rolling that occiput in the bowl, right? Whereas a lot of the other anterior occiput adjustments that we do, we end up on the zygomatic arch. We're in all these different places that we're putting a force through the face or whatever to try to get the occiput, you know. And I don't think it's as good. So I have to decide what I want to show you for that.
You gotta have the group and stuff too. Got to.
Well, you don't have to have the headpiece. Think outside the box. You got a piece of foam. You have a pool noodle. You have a thick towel that you can roll up. Hey, if I can adjust in a bar in Austria, Switzerland, wherever I was, you can adjust it. Right?
Just relax.
Okay. Finger. I'm going to come around, take my skin slack out. Press that finger into the palm of my hand. There. Traction and laterally flex by bringing my hand into me. So I'm bringing it towards correction to take out the slack.
And segmental contact points, the
Segmental contact point is the articular pillar.
right.
The left.
Okay.
Okay? Right hand, left pillar. I'm just starting over here to get my skin slack.
Okay.
I'm going to end up on the left. My finger is crossing over the spine only because my contact has to be here, on the left. Okay? Anything else? See you on Friday.